invite him to join.
Yes.
You are now connected to.
Yeah, the host has now muted everyone. The panelists can unmute themselves. Can we have the slides, please? The introduction slides. Yes, thank you very much. A very warm welcome to 147th edition. A very practical topic, a very erudite speaker, very learned speaker, and chairpersons, depression in medically ill elderly patients. So what are the challenges and how to deal with them? So the participants will be on the mute mode. You can put the questions in the chat box, and in the discussion, we'll take all the questions to the resource person. Next slide, please. Handing over the session to Professor Dr. Tufan Pati sir. Sir is the chairman of this program. Sir, please chair this program and take it forward. And apologies for not reading your CV.
Thank you very much. We will save time because we appear every Thursday over here. And it is my formal duty to introduce Dr. Alim Siddiqui, Treasurer of IPS, and Dr. Amrit Patudasi, President of IPS Research Advance Secretary of IPS Sundunar Branch and ex-CC member. And they are our vibrant moderators. Please gloss over the slides, Dr. Amrit Patudasi and Dr. Alim Siddiqui. And I have the pleasure to, next please, our chairpersons, Dr. Kaustubh Chakravarti from West Bengal. He is Associate Professor and HOD Psychiatry in JNM Hospital, Kalyani, Nadia, West Bengal. He is a life fellow of IPS, convener of IPS Research, Education and Training Foundation Subcommittee, Honorary Secretary of IPS West Bengal State Branch, Nodal Officer DMHP Nadia. He has received Sharda Menon Gold Medal in DNB Psychiatry Final Examination, Fellowship of Japanese Society of Psychiatry and Neurology in year 2011. Dr. R.B. Davis Suresh Award in 2021. He has contributed to 9 book chapters and 27 papers in international journals and papers in national journals 40. With this, we have our elite chairperson, Dr. Kaustubh Chakravarti. I shall be introducing Dr. Abdul Qadir Jilani, who has not logged in by now, but he'll be logging in very soon. I take this time to introduce him. We'll welcome when he joins. Dr. Abdul Qadir Jilani, Associate Professor of Psychiatry, Department of Psychiatry, Dr. Ram Manohar Lohia Institute of Medical Sciences, Lucknow. Postgraduate in Psychiatry in 2010 from KGMU, Lucknow. Specialized in Geriatric Psychiatry 2014 from KGMU, Lucknow. Secondary DNB in Psychiatry in 2012. Member and Fellow of many national academies. Life member of IPS. Member of Indian Association of Social Psychiatry. Member of Indian Association of Geriatric Mental Health. Member of IMA. He has received many awards. These awards include International Young Psychiatrist Travel Grant, WPA World Congress Psychiatry dated 8 in 2017 and 12 in 2017, Berlin, Germany. And national awards include Young Psychiatrist Track Award, 22nd World Association of Social Psychiatry dated 30th November 2016 and 4th December 2016 in New Delhi, India. Welcome Dr. Abdul Qadir. When he comes, we'll be welcoming him. I hand over the further proceeding to our chairpersons. Dr. Kaustubh, please take over and introduce the speaker.
Thank you, sir. Thank you, Dr. Tufan Pati, Dr. Alim Siddiqui. Am I audible clearly?
You are quite audible.
And Dr. Amrit for inviting me in this 147th edition of Thursday Music. It is quite a big show of IPS, I must say. Today, Dr. Janhavi Kedare from Mumbai, a very senior psychiatrist, she will be speaking on management of depression in medically ill, the therapeutic challenges and the psychotherapeutic armamentarium that we have to treat these patients. She is additional professor in Department of Psychiatry in TNMC and BYL, Nair Hospital, Mumbai. She has more than 25 years of clinical experience. She works in the field of geriatric psychiatry, community psychiatry, and ethics in research. She also holds the position of President, Prevention of Sexual Harassment Committee of the same college, same hospital. She is also the convener of the CPG Guidelines Subcommittee IPS, chairperson of the Awards Committee of IIGMH, and member of Institutional Ethics Committee of TN Medical College. She was the past president of Bombay Psychiatric Society and past honorary secretary of Indian Association of Geriatric Mental Health and past honorary secretary of Bombay Psychiatric Society. She had more than 38 publications, and she's also involved in public awareness through newspaper, magazine articles, radio and TV programs. Just a few lines about the topic which she will be discussed. This is a very frequently discussed topic, but every time we hear it or we listen to the topic, we learn new things. Geriatric population is a very difficult to treat population, I must say, because of the pharmacodynamic and pharmacokinetic changes in their body that they have, and also multiple comorbidities. These patients usually receive around 5 to 10, 15 medications even. So it is a tricky balance to have between those medications. Side effects has to be taken care of, and there are multiple psychosocial issues in this age group. They have sensory impairment, they have social isolation, they have their friends and family members leaving the world, leaving them alone behind. So there are multiple issues that has to be taken care of, and depression, as we all know, is very common in these age groups. So also the rate of attempted and completed suicide. So it will be very intriguing to listen to Dr. Janvi Kedare. Ma'am, it's all your please.
Thank you. Thank you, Dr. Chakravarti. And I wonder if Dr. Jilani has joined. At the outset, let me thank Dr. Tufan Patti, Aleem Siddiqui, and Dr. Amrit Pattazoshi for inviting me today to speak in Thursday Musing, which has become a really prestigious platform on which national, international speakers have been enlightening a good audience, and it has really been an academic fiesta since COVID times. And it is really creditable that it has continued even after COVID and has been an excellent academic platform. So thank you so much for inviting me on this platform. And yes, Dr. Kaustubh has given very apt introduction to the topic, that is depression in medically ill patients, therapeutics and challenges. I'll share my screen now. So, as he has correctly said, it is a topic that is discussed many times, first of all, and it may not be possible to cover everything that comes under this topic. I have tried to give an outline of what are the challenges that we face when we diagnose depression in medically ill patients, and what are the challenges that we face when we treat these patients. So we all know that medical illnesses are extremely common in older population. People above the age of 65 years, more than 50% of these have at least one chronic disability, and 1/3 have one chronic condition which limits their activities. There is a lot of functional disability that is seen thanks to medical illnesses, and a large population amongst elderly suffers from chronic conditions which limit their activities. Along with that, there is sensory impairment, visual impairment, hearing impairment, and musculoskeletal problems like arthritis, which further limit their activities. As the age advances, the number of medical illnesses that accompany a person also go on increasing. And therefore, more than 50% of people above the age of 70 years, people suffer from one or more medical illnesses. 65% people have two or more chronic diseases, say like hypertension and diabetes, or hypertension and dyslipidemia, or hypertension and osteoarthritis, and so on and so forth. As a result of all this, about the contact with physicians of this population is pretty high. It's about 1.5 times that of younger population, and prescription medicines that they take are also plenty. Dr. Kaustubh mentioned the figure of 5 to 10. Yes, 10 is almost an average number of medicines that an elderly person consumes every day. And as we go along the talk, we will realize how important that number becomes to us when we try to prescribe an antidepressant. And therefore, diagnosing depression in such a population that is already ill in some way becomes a challenge. One of the reasons being medical illness itself predisposes a person towards depression. What happens is that medical illness causes a lot of stress, a lot of functional disability leading to dependency on caregivers. There could be interpersonal issues. There could be coping issues on the part of the patient. Medical illnesses lead to chronicity and disability, leading to life changes in the patient. Other psychosocial factors like socioeconomic status, which will affect affordability and accessibility to healthcare system. All of these predispose a person with medical illness to depression. And so medical illnesses cause depression as a part and parcel of their clinical features. Medical illnesses can be an etiology of depression, or because of the psychological stress caused by the medical illness, depression may occur in an elderly person. So in people who have chronic illnesses, there is a 50% greater risk of developing depression. For example, in coronary artery disease, it has been observed that the risk increases by about 60%. Medical illness causes loss of functional capacity, social contact, and because of that, a sense of well-being also. All this causes depression. What is different in depression of younger age and older age is the clinical presentation of this depression. And what is this clinical presentation? It is observed that medical illnesses have their own symptoms, and these symptoms overlap with the symptoms of depression. There are common symptoms like sleep appetite disturbances, like fatigue, pains, aches and pains, general slowness in motor movements, psychomotor retardation, which are common to medical illnesses and depression. And there is also a stigma associated with the fact that how can I suffer from depression? Or how can I feel so sad all the time? Or how can I let it affect my psyche? I have to be strong enough to face my medical illness. There is a lot of stigma associated with accepting depression. All this leads to presentation of depression through physical symptoms. And we see that many patients who have medical illnesses and depression, they present with physical symptoms like insomnia, weight loss, constipation, sexual dysfunction, easy fatigability, difficulty concentrating. Some cognitive symptoms also start coming up. And typical symptoms of depression like sadness, loss of interest may or may not be present in these patients. And therefore, when we look at various diagnostic categories that have been offered to diagnose this kind of depression, we realize that in elderly people, especially those with medical illnesses, it may not be possible to diagnose major depressive disorder. There will be a certain population that would give classical symptoms of sadness, loss of interest, the cognitive triad, easy fatigability, loss of concentration, sleep appetite disturbances, and all the criteria that we speak about. But there is a major chunk of patients who do not fulfill these criteria of major depressive disorder, and they present in various ways. Then, still, to be able to diagnose depression in them, those who have majorly somatic symptoms and a few depressive symptoms, the concept of subthreshold or subsyndromal depression has come up. This same subsyndromal or subthreshold depression is called minor depressive disorder, other specified depressive disorder, or depressive episode with insufficient symptoms in DSM-5. These patients typically do not have sadness as a clinical presentation of depression. They may have fatigue, they may have irritability, they may have psychomotor retardation, they may present with cognitive symptoms, but typical sadness of mood may not be there. Still, these patients deserve a diagnosis of depression, and then they will have to be called as minor depressive disorder. A high percentage of patients with medical illness and depression also have anxiety as a comorbidity. I would say more than 50% of patients have comorbid anxiety along with depression. And obviously, we tend to diagnose them as mixed anxiety depressive disorder. Chronic medical illnesses are associated with chronic depressive symptoms, and therefore dysthymic disorder is also seen very commonly in elderly individuals. Dr. Chakravarti mentioned about bereavement. Yes, loss of a loved one is something that an elderly person has to deal with. And that itself may give rise to certain depressive features. And an elderly person may need help while dealing with this grief that he or she is going through. After receiving an acute diagnosis of an illness, one may suffer from adjustment disorder with depressed mood. All this classification that we are talking about is based on symptomatology of depression, as to whether sadness is present or not, as to whether classical symptoms of depression are present or not, what is the severity of the disorder, what is the duration for which the patient has been suffering. On the basis of all these clinical features or the symptomatology, this classification is based.
Ma'am, I think the slides are not moving.
No, I have not changed the slide in a long time. I will change it once I finish with it.
Madam is elaborating the points, I think. Yeah.
Right, yeah, yes, that's right. According to the associated etiology, there is, of course, mood disorder, which is caused by a general medical condition, depressive disorder due to another medical condition. According to the etiology, there is a specific category of vascular depression or depression executive dysfunction syndrome and substance-induced or medication-induced depression. These are various categories of depression that we see in elderly patients with associated medical disorders. So we have, of course, DSM-5, ICD-10, rating scales which have less vegetative symptoms and more cognitive symptoms as GDS-15 to help us in the diagnosis of depression. But there is another approach. Since we have common symptoms between medical illnesses and depression, how much importance to be given to the common symptoms like vegetative symptoms, whether we should rely on the existence of cognitive symptoms of depression, whether we should include all the symptoms in our diagnosis or not. And therefore, various approaches towards diagnosis of this depression have been developed. They are inclusive approach, exclusive approach, substitutive approach, and best estimate approach. The inclusive approach, as the name suggests, it includes all the symptoms, regardless of the etiology. Vegetative symptoms, rest of the somatic symptoms, and the cognitive symptoms of depression. And then concludes whether a person is depressed or not. In exclusion approach, all the symptoms suggestive of medical illness, all the somatic features need to be excluded and exclusively cognitive symptoms of depression will be given importance while diagnosing depression. In substitution, symptoms most likely to be confused with medical illness such as fatigability, weight loss, psychomotor retardation, etc., they are substituted by typical features of irritability, tearfulness, feeling punished, social withdrawal that the patient may be suffering from, and enough weightage is given only to these symptoms to diagnose depression. Best estimate is a very convenient approach. It involves clinician's judgment. So a clinician is at liberty to decide how much importance to be given to physical symptoms and whether the physical symptom is due to depression or only due to medical illness. So with the help of this approach, but we are able to diagnose depression in medically ill patients effectively. And yes, then we can plan management of these patients. These two slides that I have described in detail, the reason for it is to make clear that diagnosing depression in medically ill elderly patients, especially when multiple medical morbidities are present, is a challenge in itself. And once we conclude that the patient is depressed, then we will be able to treat the patient effectively. Common medical conditions that are associated with depression, I have named a few, and the list can continue forever. Commonest of the lot are hypertension, diabetes, ischemic heart disease, cerebrovascular accidents, stroke, hypo and hyperthyroidism, Parkinson's disease, COPD, intracranial tumors, cancer, multiple sclerosis. These are some of the conditions which are seen very commonly and which are associated with depression also very commonly. When do we diagnose depression in medical illness? We saw that it is a complex phenomenon. Occurrence of depression in medical illness is a complex phenomenon because of the kind of symptomatology. But still, whenever the onset of depression occurs for the first time in old age, usually there is a lack of family history. If one can associate occurrence of depressive features with recent change in health status or medication management or appearance of a new symptom, along with that, if one can associate it with the appearance of concurrent cognitive deficits, and when there are overlapping symptoms leading to partial expression of depressive symptoms, then one should diagnose depression in medical illness. Why is it important to diagnose depression in medical illness? First of all, it's a double-edged sword in the sense, unless medical illness is treated, depression would not respond. Unless depression is treated, medical illness is not going to improve. And therefore, it is really essential to be able to diagnose both the conditions and to be able to treat them effectively. Impact of depression on medical illness is such that somatic symptoms usually get exaggerated, and it sometimes becomes really difficult to judge the severity of the medical illness. I'm sure many of all of the clinicians get references saying that the back pain the patient is complaining of is in excess of what the MRI finding is suggestive of, or the abdominal pain that the patient comes with repeatedly is in excess of the pathology that actually exists. And therefore, somatic symptoms do get exaggerated. Depression in medical illness causes functional impairment, affects day-to-day functioning, and affects quality of life of the patient. It decreases the motivation of the person. It causes despair regarding prognosis of the medical illness. Therefore, affects treatment adherence. Patient loses hope, stops taking self-care, and then automatically the outcome of medical illnesses also becomes poorer and poorer. So there is a direct impact of depression on any medical illness. One of the studies conducted by Alexopoulos concluded that as severity of depression increases, quality of life, physical and mental functioning declines, and disability increases irrespective of presence of medical illnesses. And of course, in addition to the presence of medical illnesses. In presence of multiple physical illnesses, as we saw, it is difficult to diagnose depression, and therefore depression goes unnoticed and untreated, something that we should be really careful about. So what I am going to do is I'm going to describe a few cases and probably raise a few questions and try and answer them. So in this case, Mr. A 73-year-old male patient, known case of COPD, has been referred by chest medicine department with complaints of inability to sleep, loss of appetite, easy fatigability, irritability towards relatives, especially wife, aggressive behavior, sometimes even anger outbursts, and decreased social interactions. All symptoms, except probably a lot of anger outbursts, very common with a chronic condition like COPD. And then do we diagnose depression in this kind of a patient? Therefore, this brings us to the next part, and that is assessment of the patient. How do we assess a patient in whom we are suspecting depression and there are a lot of comorbid medical illnesses? So detailed history from all sources. That means from the patient, from the relative. If somebody is giving nursing care to the patient, that person. If the patient is admitted, then the nursing staff, the clinician who is attending the admitted patient. All these become important sources of information for us, and we need detailed inputs from all of them. Along with all the physical history that we get, it is essential that we look for core features of depression. And therefore, we have to make inquiries regarding existence of sadness of mood, loss of interest, crying spells, helplessness, hopelessness, worthlessness, etc., and look for presence of depressive cognitions. We also need to assess severity of symptoms. For example, how much weight loss has occurred, how severely sad the patient is feeling, how much is the loss of interest, is the patient suicidal? Such history about depression becomes very important in planning effective management. We look for past history of depression, family history of depression. Of course, this could be 7th episode of depression in a patient's life, in whom depression is pre-existent. History of medical illnesses that the patient is suffering from. Since how many years? What is the severity of the illness? What is the present status of the medical illness? And of course, treatment history. Treatment of medical illness, all the medicines that the patient is taking, and of course, treatment of depression if the patient has been treated in the past. Psychosocial assessment becomes extremely important in these patients. One reason is that it affects or it causes or may contribute to the causation of depression. One, management of the patient would definitely be affected by various psychosocial issues that he or she has. And the third important thing, pharmacotherapy, though we use very, very commonly, recommendation is that one should go for psychosocial interventions even before starting pharmacotherapy. And therefore, assessment of the psychosocial factors of this individual becomes very important. Assessment of social support, that is the extent of social support, the strength of the social support that the patient has, and reliability of social support, all become important. What does it mean? It means how many caregivers are there? Who is looking after the patient? What is the interpersonal relationship with the patient? Is there love and affection given by the caregiver? Are they capable of looking after the caregiver, looking after the patient? Are they willing to look after the patient? So all these issues we need to look at. Also, what is the amount of time that is spent by caregivers with the patient? What is the nature of relationship? All this needs to be assessed. Socioeconomic issues become important. because there is dependency that we need to look at, and also the cost of treatment, whether the patient can afford or not. From patient's perspective, interpersonal relationships, loneliness, perceived poor health, perceived poor social support, lifestyle issues like dietary habits, whether involved in any physical activity initially or not, the kind of social network and hobbies that he or she has, what kind of coping strategies the patient utilizes. Does he use more of emotion-oriented coping, or his style has been problem-oriented coping since the beginning? What is the history of substance use? Is there any change in the substance use pattern? Has the substance use increased now that the patient has got medical illness as well as depression? And I think an inquiry into the spiritual attitude of the patient is also extremely essential when we are planning management for these patients. Of course, a thorough physical examination, proper mental status examination, cognitive assessment with the help of screening instruments. We can definitely use rating scales to assess the severity of depression so that longitudinally we can look at the improvement also. And then getting the patient investigated so that we know what is the status of the medical conditions. If a medical illness is still undiagnosed, it gets diagnosed at this stage. While choosing our medicine, we have some background as to what the reports are like, and we can monitor this patient better. And therefore, baseline investigations is a must when we are treating these patients. We must remember that medications themselves can cause depression. And this is one short list of medications that can cause depression, because the list can be really unending. So there are ACE inhibitors, calcium channel blockers, digitalis, beta blockers can cause depression. Chemotherapeutic agents can cause, anti-Parkinsonian drugs can cause, stimulants can cause depression. Even anti-infective agents like chloroquine, griseofulvin, and cyclosporin. Of course, steroids are notorious to cause depression. Benzodiazepines and simplest drug like an antacid, cimetidine, can cause depression. These are some of the commonly used drugs, and we should be aware that these drugs can cause depression. We can liaison with the physician or any other specialist who's treating the patient, can make them aware that this particular medicine may cause depression. So probably he or she can look for an alternative. And if it is not possible, then we may accept that, okay, depression caused in this patient could also be because of the medication given to him. So let's come to the challenges in managing these depressed patients. Clinical presentation of depression may vary from classical presentation, and that itself can pose a challenge in diagnosis. We have already seen this in detail. Age-related decline in physiological reserve can lead to decline in functioning of multiple organs and may lead to failure also very fast. And therefore, physiology, the metabolism changes. What happens is that the clinical presentation of medical illnesses changes. For example, an acute MI may present like a painless delirium and can be really misleading at times, because one would wonder why the patient has got delirium. Or on the other hand, any appearance of a new symptom may push a patient towards a psychiatric illness and may push a patient towards depression. Similarly, because this physiological reserve is decreasing day by day, there is a very narrow margin of safety of the drugs. And when we start any medication or titrate the dosages, we have to be extremely careful. So here is Mr. B, a 67-year-old male patient. He has been brought by relatives with history of withdrawn behavior, irritability, insomnia, sadness of mood, crying spells, feeling helpless, hopeless, worthless, expressing suicidal ideas, refusing to take medications and to follow up in physiotherapy. history of right-sided hemiplegia with aphasia, history of hypertension and diabetes since many years. This is a classical case which many of us would encounter, and post-stroke depression is one of the commonest complications after stroke. It is seen in about 30 to 40% of patients of stroke. Treatment is essential because it facilitates faster rehabilitation. If we do not treat stroke properly or the depression properly, cognitive functioning may deteriorate further, and therefore it is essential to treat this depression. It also enhances motor recovery because patient starts cooperating, and of course, because treatment adherence also improves, it reduces mortality. While treating depression, comorbid medical conditions and concomitant medicines, they have to be taken into consideration. In this case, fluoxetine, citalopram, and nortriptyline are widely recommended, and Maudsley says paroxetine is the drug of choice. Vortioxetine gives an additional benefit on cognition and does not interact with warfarin or aspirin, which is an advantage in patients with stroke. Risk with SSRI, of course, is hemorrhagic stroke, and one has to be careful. Mr. C, 70-year-old businessman following a loss in business, suffered from a heart attack. He was advised CABG. Initially, he was reluctant for surgery. Ultimately, he underwent surgery and decided to take leave from office work for 3 months. But now what happened is that he started refusing to go back, saying that he doesn't have the strength. Complaints of loss of interest, hopelessness, anhedonia, ruminations about health issues and business loss. So these are some special populations where we see depression associated with medical illness very commonly. And there are specific considerations when we manage this depression. As we saw in stroke, in ischemic heart disease, SSRIs are the drug of choice. Bupropion also helps. It is safer for patients with pre-existing cardiac disease. Obviously, avoid TCAs. ECTs may be given if the patient is cardiologically fit. And selection of antidepressant is based more on the side effect profile so far as cardiac illnesses are concerned, and drug interactions have to be kept in mind. In all the cases that I'm going to describe, whatever one or two more that I'm going to talk about, liaising with the treating physician or the specialist is extremely essential so that the benefits given to the patient are maximum. Now we have a patient who is a 75-year-old Mr. D who was diagnosed to have Parkinson's disease, another debilitating disorder, commonly seen disorder associated with dementia, but depression is highly prevalent. Along with depression, a high proportion of anxiety disorders is also seen in Parkinson's disease. And treating depression, in fact, it is one of the non-motor symptoms of Parkinson's, and sometimes patients present with depression first and then the Parkinson's gets diagnosed a few months later. And therefore, treating this depression becomes really important so that quality of life in patients of Parkinson's improves drastically. Gradually, it was observed in this patient that he became very withdrawn, would keep to himself. He stopped going out of the house and playing bridge, which he was very fond of. He also started complaining of forgetfulness. How do we treat depression in Parkinson's disease? Well, there are specific scales, by the way, to assess Parkinson's depression as well as anxiety disorder associated with Parkinson's disease. SSRIs are preferred because of better side effect profile. Once again, bupropion is a good drug to give in Parkinson's. TCAs, of course, are more efficacious, but again, side effect profile is really not so good. Nortriptyline gives rise to less side effects compared to amitriptyline, and therefore is a better choice compared to amitriptyline. Parkinson's in severe depression may be given ECTs, and a transient benefit in Parkinson's symptoms also may be seen with ECTs. But avoid drugs like amoxicillin or lithium in patients of Parkinson's disorder. Mr. E, a chronic smoker, 70-year-old, he complains of breathlessness, especially on exertion, frequent cough, repeated admissions. Now not taking medicines regularly. He has restarted smoking and also consumes alcohol. Expresses hopelessness, helplessness, and worthlessness. A lot of issues, non-adherence, substance use that has increased recently. Typical depressive features are seen, and non-adherence is probably leading to exacerbation of the existing medical condition in this patient. So these are some of the very difficult issues which one needs to handle. Choice of antidepressant also will depend on his medical condition, where we cannot really give benzodiazepines for insomnia, but still we may have to select a sedating antidepressant, avoid MAO inhibitors, and probably we may have to consider whether the depression is also caused by drugs. So there are multiple factors that we need to take into account when we are treating depression that is associated with medical illness. These examples that I took are very typical examples for which we keep getting references. And there are many more which present to us with complex symptomatology, a lot of interaction between the medical illness and the psychological factors, giving rise to depression and posing different challenges in the management of these patients. Malignancy is yet another condition where there are a lot of risk factors for depression. Advanced disease, pain, tumor site itself, social factors, psychological factors, psychiatric morbidity, and treatment-related factors give rise to depression. There is a high prevalence of depression in patients with especially pancreatic cancers, oropharyngeal cancers, and breast cancer patients. We all know that paraneoplastic syndromes, which lead to hypothyroidism and hypercortisolism, they can definitely lead to depression. And there are a lot of social issues when caring for the patient with cancer comes into picture. There are a lot of socioeconomic consideration when malignancy is to be managed. And all this may lead to depression in a patient of malignancy. Once again, how to manage? Of course, keeping in mind concomitant medication, drug interactions, organ failures, impairments that are existing, our antidepressant will have to be selected. SSRI, of course, is the first line of treatment, also beneficial in managing neuropathic pain. Psychostimulants, methylphenidate is advocated for treatment of malignancy-associated depression for rapid onset of action, promoting a sense of well-being, decreasing fatigue, stimulating appetite, potentiating the analgesic effects of opioids, and of course, decreasing opioid-induced sedation also. Recent studies have also indicated a role for ketamine in management of pain associated with malignancies. Psychological interventions with a focus to reduce emotional distress, improving morale, basically instilling hope, optimism is the goal of treatment in these patients. And along with that, of course, improving social support of the patient helps in better treatment outcome of these patients. Now let's come to a very important concept of vascular depression. We need to consider it a little separately because these are the patients who have a very typical way of progression with very typical findings on neuroradiological examination, with such risk factors which can be modified or can be controlled and has a higher risk of progressing towards dementia. So in contrast to depressive disorders in younger adults, late life depression is associated with cerebrovascular comorbidities and microvascular lesions. These get represented on MRI as white matter hyperintensities, usually on the structural magnetic resonance imaging. Of course, there are lacunar infarcts, subcortical lacunae, microbleeds, also frontal and temporal gray matter changes, especially hippocampal atrophy, and neurodegenerative pathology is seen, as well as biochemical changes are also, related biochemical changes are also seen. Previously, there was an old concept of atherosclerotic depression. Now it is known as vascular depression. In 1997, Alexopoulos, he proposed a vascular depression hypothesis. Cerebrovascular disease, including small vessel ischemic changes, structural damage to frontal subcortical circuits with disruption of corticostriato-pallidothalamo cortical pathways. Corticostriato-pallidothalamo-cortical pathways, disruption of this pathway may predispose, precipitate, or perpetuate geriatric depressive symptoms, is the hypothesis by Alexopoulos, and that was called as vascular depression. Now, vascular depression accounts for up to 50% of depressive diseases in the elderly, is one of the recent findings of MRI-based studies. Krishnan et al. Defined MRI-defined vascular depression, and they said that there is a distinct clinical and neuropsychological profile and a positive association with hypertension in these patients. MRI literature supporting vascular depression hypothesis shows that loss of brain volume and white matter integrity are associated with poorer clinical outcomes in these patients. So to establish a diagnosis of vascular depression, what are the criteria, and when will we be able to call a patient as having vascular depression? Evidence of vascular pathology with or without cognitive impairment, absence of previous depressive episodes, that is preceding the cerebrovascular disease, presence of cerebrovascular risk factors, coincidence of depression with these risk factors, clinical symptoms characteristic of vascular depression such as executive dysfunction, decrease in processing speed, and lethargy. These are the typical symptoms that are seen in vascular depression. And of course, neuroimaging evidence confirming vascular depression. These are some of the criteria for diagnosing vascular depression. And so depression, executive dysfunction syndrome of late life also is associated with vascular depression. When vascular depression is associated with greater disability, poorer outcomes, and executive dysfunction, it is known as depression executive dysfunction syndrome or depression cognitive impairment disease. This cognitive impairment is usually in verbal fluency, naming, and initiation and perseveration. Typically, there is psychomotor retardation and anhedonia, and less severe vegetative symptoms, agitation, or guilt. This concept of vascular depression is important. Also, let us see how it occurs. There are a lot of biological changes, usually hypertension, hyperlipidemia. These are risk factors, also diabetes mellitus, leading to small capillary changes, white matter lesions, and then there are psychosocial factors, probably negative life events, insufficient social support. All this in combination with one another cause vascular depression in these patients. And what are the clinical features of vascular depression? Usually occur at the age of 65 years or above. There is usually absence of family history. We have already seen what typical clinical features are: higher cardiac illness burden, increased rates of vascular risk factors. There is a higher risk of cognitive decline and progression to dementia. It has a fluctuating course and greater treatment resistance and poorer outcome, and it is associated with increased mortality. These are typical clinical features of vascular depression. And while treating vascular depression, as we treat depression, we also need to look at the vascular risk factors and try and control those vascular risk factors. So ultimately, coming to management of depression in medically ill patients. Well, medically ill patients with depressive features, we have seen what are the differences between typical depression and these, and what are the diagnostic challenges these patients pose for us. Once we establish a diagnosis of depression, with the help of our assessment, which includes a good mental status examination, using rating scales, a thorough physical examination, and carrying out baseline investigations. Along with that, we have also said that assessment of functioning, level of functioning, social support, psychological competencies, and assessment of cognitive functions is essential in these patients. After this comes the part of deciding the treatment setting. Whether we want to treat a patient on outdoor basis or we want to treat the patient on indoor basis. Patients where definitely there is suicidality, catatonia at times, when there are multiple comorbidities making the picture really complicated. At times, patients present with a lot of side effects of medications that the patient is already taking. Such patients need to be admitted. ECTs is the first line of treatment for patients who are actively suicidal, severely depressed, catatonic, and in whom there is a past response to ECT. Doing ECT workup, getting anesthesia fitness may take a while depending on how the existing medical illness is, whether it is controlled, whether the treatment adherence on medication has been good on the part of the patient. All this will decide when and how we will be able to give ECTs, but yes, such patients need to be given ECTs. Then, of course, there are two components of therapy, pharmacotherapy and non-pharmacological treatment. Selection of drug becomes an important issue. Past response, if there is a past history of depression, efficacy of the medication, side effect profile, they play an important role. Depending on the kind of medical illnesses, we have just seen about 4 or 5 examples of various medical illnesses and which drugs we chose for what reason. And therefore, comorbidity decides the choice of treatment for the patient. Cost becomes an important point because if a patient has to take 10, 15 medicines every day, then the cost of medication becomes an important issue so far as treatment adherence is concerned. And sometimes patient preference becomes important. It is actually preferred if we start with non-pharmacological management. All the newer guidelines say that, especially in medical illnesses, along with pharmacotherapy or even before pharmacotherapy, non-pharmacological treatment should be considered because there are issues in selecting a proper antidepressant, in treatment adherence, and the side effect profile, drug-drug interactions. I think we have not dealt with an important part, and that is drug-drug interactions. Every medicine that the patient is consuming, we need to look at and then select the antidepressant accordingly. So psychoeducation regarding depression, regarding medical illnesses, regarding a need for treatment, regarding a need for treatment adherence, side effects of medicine, early signs of relapse, all this has to be told in psychoeducation, and there are various choices of psychotherapy that a patient may be given. Along with this, of course, continuous follow-up and watching for early signs of relapse is important. So how do we, what are the principles of pharmacotherapy? Rule of maximal simplification is used. Let's simplify how much ever it is possible to treat the patient's treatment. So we start low and go slow. That is the first principle. Second is, see what all medicines the patient is taking. Sort out those medicines. Stop all those medicines with high potential for causing psychiatric symptoms, for example, for causing depression. At least consult the treating physician and ask him whether the medicines can be stopped. Continue all the medicines that are actually necessary for the treatment of medical illness. You will realize that once you review the medicines, there are at least 3, 4, 5 medicines which do not have a role actively in the present medical treatment and are just being continued like that only. Stop all these extra medicines. This gives you a better choice from the set of medicines that are available to you, and then one can select the proper appropriate medicine which can be given to the patient. So once you start a patient on the low dose of antidepressant, increase the dose if compliance is good. All this is from the IPS clinical practice guidelines on geriatric depression, where they have suggested how increments in dosages should be done. Increase the dose if compliance is good and there is no response in the first 3 weeks. Wait for another 2 weeks to increase the dose if partial response. And usually response is seen in about 4 to 6 weeks. If there is no response in 4 to 6 weeks, then of course you need to reappraise, decide whether the patient is responding or not, probably adjust the dose, probably change medication or add an adjuvant, decide the further course of action. It is important to remember that elderly patients take longer time to respond to medication. How do we choose the drug? Depending on the efficacy and side effect profile, depending on the drug-drug interactions. There are Beer's criteria. Beer's criteria give a long list of medications which are inappropriately prescribed in patients beyond the age of 65 years. That means these are the medicines which have to be avoided in patients who are more than 65 years. And so we need to look at the list. Look at the list of medicines that the patient is taking. Think of probable drug-drug interactions. That means we need to be aware of the pharmacokinetics and pharmacodynamics of the medicine that we are planning to start. We should be able to look at the pharmacokinetics and pharmacodynamics of the existing medicines that the patient is on, and then make a decision as to how much dose, which antidepressant, how to increase the dose, etc. Of course, start slow, go slow is the principle. Work on treatment adherence, liaison with other specialties, and whenever possible, whenever necessary, perform necessary investigations. We may have to monitor blood sugar, lipids. We may have to monitor renal parameters, hepatic parameters to look at the side effect profile of the patients. Psychotherapies are very important while treating this depression. Impact study included 1,801 patients, and they showed that with problem-solving therapy, there was better compliance and better remission of depression, better outcomes in quality of life, self-efficacy, and physical functioning. There is enough evidence for CBT and for interpersonal therapy also, which was demonstrated by PROMISE-D study conducted by Alexopoulos. Well, the slide is not very good, but the idea is to demonstrate that yes, there is CBT, problem solving, interpersonal psychotherapy, reminiscence therapy, and brief dynamic therapy. I have taken the chart from IPS clinical practice guidelines on geriatric depression. You can always go back and look up that chapter, and you will realize that there are a lot of important points in that article which help us in treating these patients. We've already seen about ECTs, the potential risk and benefit should be weighed on case-to-case basis. There is increased risk of complications in people who are on more number of medications, especially cardiovascular medications, and this is something we need to keep in mind. And of course, recent studies have shown that cardiovascular complications arising due to ECT are transient, some relief to us, okay? And don't prevent successful completion of treatment course. So that means we don't have to be scared of these cardiovascular complications, but yes, we have to be little vigilant about them definitely. RTMS seems to be having some role, and vagal nerve stimulation has been talked about. So ultimately, when we talk about therapeutics of managing depression in medically ill elderly patients, what are the challenges? Challenges are in the clinical presentation and therefore in the diagnosis, various investigations that we need to do, because longitudinally we will have to follow up and look for improvement, deterioration in medical illnesses as well as in depression and in cognitive impairment also. Management of concurrent medical illnesses and management of depression. These are the challenges that we face when we are treating depression in medically ill, depressed individuals. Thank you. I'll stop sharing the slides.
Thank you so much, ma'am. Very enlightening, very breezy, easy to follow lecture. So over to chairpersons for their opening remarks. Dr. Jilani is also joined.
I think it's turn for Dr. Jilani. Yeah, so please. Dr. Jilani, please unmute yourself. Hello.
I think his internet is.
Yeah, I think he's stuck to presenter. Yeah. So let me go through the chat box. If I think there are not many questions. Somebody wanted a clarification regarding methylphenidate seems unlikely to cause depression. It is even used
withdrawal.
Yeah.
Correct.
So that is well taken. I think it's okay. Ma'am, how to go about optimizing mood disorder about a pre-existing mental illness like BPAD, who maintained well of lithium and later in life developed Parkinson's disease? Would stopping lithium would be advisable?
Yeah, I think it will have to depend on. Yeah, I think Dr. Jilani wants to say something.
So Jilani,
Yes, ma'am.
Yeah.
Thank you so much. You have covered all the various aspects of the depression in medical, from the clinical presentation, from the various causes like the malignancy, the very trivial causes like the chronic pains, even a low back pain in the elderly or knee pain in the elderly, which is, if ignored, that may cause a depression. Even a patient with a bedridden in the elderly with a fracture of neck or femur, he may develop depression over a period of time. There are the several conditions we usually see, as you well explained, like the medication. And one very important factor, even in the elderly patient, due to the age process, age-related neurodegenerative changes, chronic medical illnesses, and the treatment for their chronic medical illnesses. Along with these, they have become very prone to develop depression for the trivial issue or trivial stress. If for a younger generation have a severe amount of stress, the elderly over the trivial stress may develop the depression, and that even may not related to the underlying medical illness. But the underlying medical illnesses have weakened the person threshold, or you can say the immune system. And with you, something I want to say here, that a very important factor we often see, that is even that may lead to the depression, or that is the adverse effect of the treatment of depression, like the electrolyte imbalance, which is very common in the adult. Even a person due to some medical condition, with the treatment of hypertension or with the diuretics, he may develop the hypernatremia over a period of time, and he may present as a depressive symptom. And we have also seen that they are the elderly patients who are given antidepressant, and their depression symptoms worsen, not due to the antidepressant, but due to the side effect as he developed the hyponatremia and the SSRI. So these are very important points which I want to add. And very important one thing that in most of the malignancy, especially in the gastric malignancy, starting from the esophagus, pancreas, intestine, in this type of malignancy, the depressive symptoms are, and you very well explained that there's a partial expression of depressive symptoms, not the full expression. That we should have doubt that the patient may have developed is in depression. So these are the few things which I wanted to uh, point over here. And very common point in my clinical practice, especially in the geriatric, I see even the pulmonary infection, even the UTI, and even a chronic constipation. These three, and the fourth is the hyponatremia. These
Yes.
four factors we commonly encounter that either they are enhancing the depressive symptoms or they are a risk for the depressive symptoms. Uh, uh, these are the very common.
Yes, thank you for all your comments, Dr. Jilani. Very, what should I say, very appropriate comments. And yes, you brought out a very important topic of hyponatremia, especially when we prescribe SSRIs, we have to be very careful about two issues. One is hyponatremia and the other is the risk of gastric bleeding. Or bleeding tendencies. Let me not call it just gastric bleeding. These are the two issues that we need to keep in mind when we are using SSRIs, especially in elderly individuals. And with multiple medical comorbidities and other medicines, the risk of these complications increases. Patient suddenly presents with delirium and we wonder what happened to our depressed patient, and then we realize that it's hyponatremia. There are some 2-3 questions in the chat box which I noticed, and I think I need to address them. Yes, the question about renal failure, usually SSRIs as the first line of treatment for renal diseases, and depression can be treated with those. There is also another question about treatment resistance in post-stroke depression. I think we must remember that it is a combination of pharmacotherapy and psychotherapy that is going to work in these patients, and therefore we must give a good trial of psychosocial interventions also in these individuals. Otherwise, treatment resistance will have to be treated like any other treatment resistance, but the choice of medicine and the selection of our antidepressant will probably differ a little bit compared to our younger age group patients. Similarly, I would also say about the question on bipolar affective disorders, whether lithium should be stopped. As is the case with any age group, even in elderly individuals, it is the risk-benefit ratio that will decide all these decisions that we make. But yes, sometimes lithium may have to be stopped in these patients, but there is no particular recommendation saying that you cannot prescribe lithium in old age. And therefore, I don't think one has to stop lithium. Once again, depending on the kind of conditions that the patient has and the drug-drug interactions that we're talking about, we will have to look at all that and then decide about the choice of medicine, even in pre-existing bipolar affective disorder. Means, why do we worry only about bipolar affective? It is same for schizophrenia, other psychotic disorders. So all the psychiatric illnesses that we see in elderly, ultimately, which have been pre-existent for many years, management will get complicated as the age advances. I think these were some of the things that I had noticed in the chat box. If there is anything else,
There are a lot of congratulatory messages for you.
okay, thank you.
So, and many other questions are also there. I think.
Okay, mirtazapine may be good choice in cancer patient. Yes, very true. But again, side effect, anticholinergic side effects we have to look at, blood sugar levels we have to look at. So it is always, yes, probably, especially if he's talking about gastrointestinal malignancies, then better avoid SSRIs and go for something else. So these selection of antidepressants will, of course, be affected.
Question regarding vortioxetine also.
Oh yes, vortioxetine, there is some data saying that yes, it does help in cognitive improvement, and therefore helps in cognitive impairment. And for cognitive symptoms, basically we do give vortioxetine, and yes, we may give it in elderly patients.
Okay, ma'am. Two questions are on the lines of how long to continue treatment. In first occurrence, after the treatment, after the depression is now recovered, depressive symptoms are now recovered, and for methylphenidate, how long to give? So basically, how long new medications after the symptomatic improvement?
Okay, so the IPS clinical practice guidelines have said that it takes longer for the patient to improve, elderly patients, and therefore 6 months may not be sufficient if you are if you are starting the patient for the first time. Therefore, you may have to continue the treatment. They have not specified the time duration for which, but I'm sure depending on the clinical improvement of the patient, we will have to decide the duration. I would say methylphenidate also, as is true for other antidepressants, we'll have to decide the duration. How means we prescribe it in children also for ADHD. We don't say give it only for 4 weeks or 6 weeks, depending on the need of the patient, we give it. So accordingly, we will be giving it in elderly population also. If our chairpersons have to contribute something, they can definitely opine on this.
So there is another interesting question actually. A 60-year-old male patient marries 35-year-old lady after that of first wife and presented with complaints of ED and depressive symptoms.
Yeah.
So what should be the treatment approach?
Oh, yes. Okay. First of all, we may have to go into the cause of erectile dysfunction in a way, means whether it is an erectile dysfunction, whether it has come as a part and parcel of our depression, whether it has been caused by the antidepressant, or whether it has been caused by a medical illness like diabetes mellitus. I think that will also decide the treatment of erectile dysfunction, whether we need to give him specific treatment, specific drug for erectile dysfunction. But yes, choice of antidepressants, though they talk of SSRIs, they have said paroxetine is better in these cases. In ejaculatory difficulties, they have spoken of fluoxetine. They have talked about now vortioxetine also. The newer choices are better according to the data. And here, I don't think there is any difference between young patients and old patients. The choice of antidepressant will remain the same irrespective of the age group.
And so, ma'am, if the patient has, Jilani, please.
The one important question: which one will be better, giving medication in divided doses or in single, especially for the elderly, as someone had asked the child.
Okay, so well, it is like this, that how sedative the medicine is, then maybe whether the whole dose should be given in the night or should be divided. How many medicines the person is taking throughout the day. If he is taking 7 drugs 3 times a day, can we decrease the number of medicines that we give during the day? So our decisions will depend on certain practical issues like this. And of course, our medicines, they themselves have certain conditions, means amitriptyline probably you will prescribe twice a day. Escitalopram you need not prescribe twice a day. You can give as a single dose. Mirtazapine you can give as a single dose. But if it is too sedating, then maybe you will divide it into 2 dosages. So depending on, means it will differ from case to case, depending on the clinical picture, what is the necessity during the day, what kind of, means do we want to make use of anti-anxiety property of the medicine during the day, and therefore we want to give a dose in the morning. All these considerations will decide the way we treat the patient. Okay, endoxifen in older adults, very frankly, I am not very well versed with endoxifen in older adults. I have not really read any literature in older adults. If anybody wants to enlighten, please go ahead and do it.
Not really, I haven't used also.
Yeah, I know. Means
better not to comment. Yeah.
Yes, better not to comment, and better maybe look up some literature and studies.
We have used in mood disorder patients with average results.
As in older, as in younger population, nothing different in older patients, right?
They have not seen any serious side effects
Yeah.
in mood disorders in terms of bipolar disorders.
No big risk, no big gain in elderly intoxicant.
Yes, sir. And ma'am, one thing regarding this depression and Parkinson's, did we discuss about this pramipexole and
Oh,
ropinirole?
yes.
So
Yes,
how
please go ahead.
what's the how do you find it there?
Yeah, pramipexole is known to be useful, and yes, I think that gives good results also. Pramipexole does help in, it is recommended for depression in Parkinson's specifically, so we can definitely use it. No doubt.
If a person has bleeding tendencies, so we tend to avoid SSRI, then what to give them?
Why we have a wide choice, I thought. We have mirtazapine, we have, though not many people have been, though not many people give, there's venlafaxine, or venlafaxine may be given. There could be nortriptyline, which can also be bupropion, is I think an underutilized drug. We don't usually
Even
use it.
dosulapine, that works.
Pardon?
Dosulapine also.
Oh yes, of course, dosulapine also.
That works very good for elderly depression.
And suppose an elderly patient is having problems in sleep. So which
Well, very frankly, the first, always with problem in sleep, it is the etiology of sleep disturbances that governs the choice of medicine, I feel. Means if it is primary insomnia, or insomnia which is secondary to a medical condition, like say, okay, patient has to get up 2 times, 3 times because he has prostatic enlargement, I think better avoid a benzodiazepine. One can give melatonin to these patients who have but generally for insomnia in elderly patients, melatonin is preferred. But if you are treating, let's say, depression, and if you want to give a sedating antidepressant, you want to give nortriptyline, you want to give mirtazapine, yes, then you should give that rather than giving melatonin or any other medicine. So I think that will decide what to give.
And ma'am, which group of medications would help in the would be sort of rather pro cognition? They will not dull cognition, and they might also help in cognition. So what medications would that be in elderly?
Antidepressants you're talking about.
Yeah.
Okay. Well, one thing is that TCS should be avoided, they have said, but we must realize that treatment of depression itself causes improvement in cognitive symptoms, and therefore which antidepressant doesn't really matter much so far as that is concerned. But yes, whether vortioxetine helps better, probably it does help better. That is, at least that is marketed as that specifically. Isn't it? Bupropion, they have spoken about, where they say that cognitive impairment or cognitive improvement will be seen better. So there are these a few choices which are there, which we know that can be given specifically for cognitive improvement. But yes, generally cognition will improve once the depression improves. That is also there. And I would say, if you look at vascular depression, it is the management of vascular risk factors that is more important for cognitive improvement.
Can I ask you one question, madam?
Oh, yes, of course.
Madam, how often do you use a memantine or a donepezil as a routine practice in geriatric onset depression?
No, I don't use it as a routine practice in depression. Unless there is dementia, I don't use it.
Late onset depression.
Late life depression, if it is associated with dementia or it is a part and parcel of dementia, yes, I definitely use donepezil and memantine. But if it is only depression, then I don't use donepezil and memantine.
Okay. Ma'am, Dr. Sai Kumar wants to ask the societal risk of elderly patient as compared to middle age or younger adults.
Yeah,
So
it is higher.
So and how to go about?
Okay. So suicidal risk in elderly patients is definitely higher than that in the middle-aged or middle-aged individual. Management of suicidal risk will remain the same as is seen in younger population. It's not that there will be something different, but yes, I think creating social support system for elderly individual, managing loneliness of this individual, managing medical conditions which may be responsible for the suicidal ideas like pain, are some important issues. Say in terminal illnesses, probably if nothing else is there, then supportive management to the patient. These are some of the things that we can definitely do to decrease suicidality. Depending on the condition of the medical illnesses, we may have to decide how to manage these patients also. Means, are they in a position where we can give ECTs? Then definitely we should give ECTs. But there is a terminally ill patient whom you cannot give ECT, then there is no point in saying that I'll give ECT to this patient to prevent suicide. Rather than that, psychosocial interventions may play a better role in that patient. So I think I will look at suicidality like in that sense. But more important than that is assessment for suicidal ideas. Means directly asking every elderly patient who is depressed about suicidal ideas is important, because one fact is that completed suicides are maximum in number in elderly individuals. And therefore, we come to know about suicide only after it is committed. Rather than that, let us try and pick up suicidal ideas that will help us in preventing suicide in these patients.
Okay. Ma'am, Dr. Idris has asked, we often come across cross consultation for geriatric patients. They are admitted for medical illnesses. And clinically now there is no depression, but long-term TCA is going on. So do we need to change it? Do we need to not change it? Continue it? What to do?
We can definitely change it. Why not? See, it's like this. First of all, why is it that the patient is on long-term TCA? Any change that we want to make, we better see why the patient is on the medication. Has the patient responded to this medicine only in this particular dose only? Are there medical illnesses and the medicines for those medical illnesses which are at cross purpose with this medication, that there are drug-drug interactions and TCAs should not be prescribed to these patients? All this will guide us in our decision about changing TCAs in these patients. Well, sometimes patient is only on 25 milligram of amitriptyline, and for years together the patient has been taking that. But it takes care of insomnia in the patient. Do we really need to change it, or do we really need to stop it? But at the same time, does the patient really need that amitriptyline 25 milligram also? What is it that it is addressing? So once again, it is our judgment, the need of the patient, a comprehensive assessment of medical status as well as psychological status will determine whether we need to continue same or whether we need to change the medicine. I hope that answers the question.
Yeah, ma'am, someone has asked about Dr. Saurabh, trazodone for insomnia in elderly.
Oh yeah, trazodone. Well, prothiadine is something that I did not talk about. Doxepin is something I did not talk about. Doxepin is another older molecule which was very popular once upon a time, and it used to help in elder depression. Trazodone is also less used molecule and a good sedating drug which can definitely be used in patients. But we don't use so much trazodone.
MRI in all cases of geriatric depression?
A new onset depression, I would suggest why not? Especially if there is some cognitive impairment along with it. It's not mandatory to do it, and it's not necessary to do it in 100% of the cases. But I would look at it like this. If there are vascular risk factors, if there is cognitive impairment coming up, post-stroke depression, these are the cases in which an MRI would definitely help. Earlier we detect dementia in these patients, the better it is. Many times in vascular depression, we pick up patients with mild cognitive impairment. then again the issues of management in these patients are very different, because you can't really start donepezil for these patients, and psychosocial interventions is the mainstay of treatment, and of course management of vascular risk factors. So there also neuroimaging does help.
Any role of cannabinoids? Any recent news on this?
In elderly patients, no, not that I am aware of, at least.
Especially in the case of malignancy, those who are suffering
Yeah,
from
that
some
is there, but
malignancy.
specifically for, means as a general rule for
that
elder
patient.
depression, I don't
And
think cannabinoids are
But
described.
the evidence is that in the patient who suffer from some malignancy, they after
The
giving the
pain.
cannabinoid patient, they the pain relief and there is some well-being feeling of
Yeah,
well-being.
sense of well-being comes with cannabis.
That's well-being. Even in the malignant patient, those suffering from some malignancy, the first antidepressant maybe the it has the anti. That's why they talk to the person. In patient malignant, as I so
Your
can
voice was,
identify.
It's cracking.
My voice is not there.
We can't hear properly.
Amrit, I think we have covered all the questions.
Yeah, almost all.
Already 9.
Almost all. Yeah,
Madam
I
has
think we
answered
should
the
conclude. Yeah.
questions.
So
We
going
cannot keep on.
going to chairpersons for their final comments. Any words of wisdom for us?
Nothing particular. I think everything has been discussed. Just one parting statement for the junior participants in this forum. Please go through all the prescriptions of the geriatric patients. Make sure that you are not repeating any medication which has already been written in the other prescription. I have seen often too many patients who have been receiving the same medication from 2 different prescriptions, and that creates a havoc on that patient. So please be very cautious and always try to summarize and minimize the medications. That is my humble submission. Thank you.
Thank you, Jilani. You missed the initial.
Espe-
I want a bigger comment from you. Lengthier comment.
Especially in the geriatric patient, the first principle is to find out whether it's really a depression or not. Second is that the make a habit of don't prescribe the medication in Italy, especially the benzodiazepine or any medication until unless there is the established depression. If there is the need of prescription of the medication in Delhi, the first thing is to start the half of the recommended dose, especially in the Indian patient, because these causes false fractures and so many side effects in the elderly. And that is the one of the major reason that we often lose the follow-up of elderly patient after the first consultation. Elderly may develop some side effects, some over-sedation, the family stop the medication due to the over-sedation. That is the very common. In Indian patient, if there is some first episode of depression in medically ill patient, or even in the geriatric patient, that is the primary depression, then the first rule is that just to prescribe the half of the medication what we feel that is good for him. And one important question whether the doses should be in the different divided dose or single dose. For the safety of the patient, this is on the clinical judgment, not on the guideline. Start the divided dose just to avoid the side effect. If you give the divided dose, if there is some side effect, if on the divided dose, the patient shows some improvement, don't give the another dose, just keep on the single dose. So that is the 2-3 very important point, what I feel. In every elderly patient, before giving the medication, and as Dr. Janvi ma'am already explained that, find all the medication which is contributing factors, repeat a fresh investigation. I know one in chat box, there is the one question that in every geriatric patient, there is the need of MRI. In almost all patients, we should go for brain scan, whether it should be CT scan or MRI, depending on the condition. Investigation is very important. After that, we should only prescribe the medication. There should be the no history of, because in elderly, as in the adult, we see the early response of antidepressant. In elderly patient, we will not see early response of the patient. In haste, due to the pressure of family members, we keep on increasing the dose or keep on increasing the number of antidepressant. But elderly geriatric depression may be, there may be the delayed response, or maybe there may be the delayed remission. In elderly, we should not be haste. In haste, there may be the side effect. There will be the no impact. What I find, because even in the elderly patient, if there is the no risk factor, there is the single risk factors of the neurodegeneration that play an important. We find in, we don't find any risk factor in the elderly, but due to the old age, there is some degree of neurodegeneration. There is some degree of white matter changes if the patient is chronic diabetic, if the patient is chronic hypertensive. In the Indian patient, even a patient who is a long-term hypertensive or diabetic, mostly they are not well controlled on the antihypertensive medication. Their sugar for the long term is not very controlled, and these are the risk factors which, for the trivial stress causes the depressive symptoms or a stress reaction in the elderly. These are the some basic things which I usually practice in our elderly.
Thank you, Dr. Jilani. Tufan sir, comments from your side.
Very much. Thank you, Dr. Jannavi Kedare, for your nice presentation. And it's a very complex issue. All of us face it. Fact number one is that as age increases, comorbidity, number of comorbidity increases. Whatever be the statistics, after the age of 70, there is all likelihood 60 to 70% of the patients will be having minimum 3 comorbidities. That is what I face. And as Dr. Lani has highlighted, and most of the diseases are ill-treated because of the non-adherence of the patient to the advice by the doctors. Second is multiple prescription. I am seeing regularly patients all being prescribed methylcobalamin by 3 different doctors by the time they come. So it is imperative on our part to review the prescription they had, and if no one has initiated, to initiate consultation liaison with the other doctors who are treating. That is in the interest of the patient. That is essential. As such, if a patient goes to endocrinologist, he does not bother to talk to a psychiatrist or someone else, even a cardiologist who is also treating. And the most important thing, this is about the patients you are talking who come to us. They have a caretaker to bring in, the family member who care for them. But in my perception, in the elderly, most of the elderly people are neglected. Not only they are neglected in their community and family, the institutions are subject to the disease of ageism. They are also there ignored. That is the first point. So psychoeducation of the families and society is most essential. That is most essential, and we have to also look for the quality of life of the family members, not the patient. At times it becomes so. Imagine about a nuclear family taking care of parents. Both of them are in rush to earn money 8 to 10. They will prefer to keep their parents in the village. That is the sin we are facing nowadays. Sir, tell us where we can keep our parents. Not prepared to spend more than 10,000 rupees a month. That is the issue. That is the real issue. Both son, daughter, son-in-law are earning, they are out. They are also busy 8 to 10 in their run for money, in their run for management. They keep their children in the kindergarten. They come to us. We want to take care of parents. To show us a place where you can keep. And they can afford around 10 to 15,000 rupees an average. This is the problem. These are the societal issues which one has to address. If we take up the lead, it has to be done. It has to be done by someone, नेहमी डॉक्टर जान्हवी करणारे ते तो डाक सुने के ना से एकला चलो कौस्तुभ चक्रवर्ती. Thank you very much.
Thank you. Thank you.
Thank
sir.
you so much. Thank you
Amrit.
so much.
Yeah. So on behalf of the IPS state branch, I would like to thank you, Janvi madam.
Thank you.
Medically depressed patients, it's one of the most complicated things we get in consultation liaison psychiatry. I think that is where, everybody is judging us, all the doctors. If you look at the ICU doctors, you look at the medicine specialists, they look through a prism. How is this doctor? And I think that's a very tough one. And madam unraveled the puzzle so easily. She spoke in such a relaxed manner. She made it very simple. I think when it comes to complicated things, if keep it simple, we do better. And that's what everybody around us has been talking. Kaustav has been talking the same. Jilani has been speaking the same. Tufan sir was speaking about how difficult it is now. It's not just about the kids. It is about the financial conditions. It is about the aspirations. The whole society has changed into a children specific now, not a family specific one. Everybody is more worried about their kids. They're not worried about the people who are looking after us. So I think the paradigm shift in the way we have focused on our parents and our kids. 99% of our finances, our resources, our time is only focused on our kids because we are so insecure. I don't know for what. And I think the paradigm shift in terms of how we think about the geriatric population is important, because I and Alim are almost on the threshold of geriatric. Even though we dye our hair and all, we are on the verge of getting into that stage in life. So when Costa was speaking that it is for the fun, Alim was almost all year. I was about to tell him we are not young anymore. So thank you everybody. There were too many questions and madam answered each and every question. And she also allowed the chairpersons to give their opinions and viewpoints. And where she was not very confident, she put it back. And that's how one should be. You should not be beating on the bush. And thank you so much, everybody. It was wonderful. Even though it was a, pharmacology specific topic, we had more than 160, 165 people at the peak and more than 220 logins. And I think that's very, very good. So
Thank you
for
so much. Thank you once again
Thank
for
you.
this opportunity given to me.
Thank you
Good
so
night,
much.
all.
Good night.
Thank you, ma'am. Kaustav, Jilani. Thank you.
Night.
Thank you, sir. Thank you, sir. Thank you, ma'am. Thank
Thank
you,
you.
Tufan, sir.
Closing the meeting, sir.
Thank you very
Yes,
much.
sir.
Yes, sir.
Good night, everyone.
Good
Okay.
night.
और सर जिलानी को बुलाएंगे पूरे उसके लिए
किसके लिए, sir?
फुल प्रेजेंटेशन के लिए